So now I call upon Dr. Ankur Sinha, please, to talk on taming the myopia pandemic.
Yes, super. Thank you, ARC, and thank you, AIOS, for giving me this opportunity. So the talk is going to be a little boring because the guidelines are usually boring. So we all know the definition of myopia, but we should also understand the definition of pre-myopia in children. These children have a likelihood of future development of myopia, and they have a refractive state of less than plus 0.5 diopters of hyperopia or more than 0.5 diopters of myopia. They also have certain quantifiable risk factors. Now, myopia is a global emerging health problem, and we expect that we will develop or maybe reach 50% by the end of 2050, both globally as well as in India. So workup of a case of myopia is similar to what we do for a pedophthal examination, but specific things to be taken care are the parental and the sibling history of myopia, the child's visual environment in terms of amount of outdoor activities, the amount of time spent indoors and in front of digital screen, and the lighting conditions at home and school. The history taking again is similar to what we talk about for pediatric opthal, but specific to myopia is age of onset of myopia, first classes prescription, amount of myopia, the history of pathological changes in the retina, history of progression, and if patient has taken any treatment before coming to us for control of myopia. The ocular examination, again, is similar to what we do for most of the ped-opthal and general exam for children, including the orthoptic workup. But we can add up axial length in terms of ultrasound biometry, but an optical biometer is more acceptable to children because it doesn't intimidate them when we try and measure the axial length for progression of myopia. Cycloplegic refraction is a must. For very young children, we can plan for atropine, short of which we can plan for homatropine and cyclopentolate, do a retinoscopy, AR can be done. Open ARs are now being propagated because they tend to minimize the residual accommodation and also the instrument myopia. They also help us in doing peripheral refraction, which is being advocated as a part of assessment in case of progression of myopia, and also try and document the myopia in terms of diopter per year. And ideally, we should try and implement the same method of refraction for a child whenever he comes for a follow-up. Now, must-do examination is the visual acuity, intraocular pressure, slit lamp, and the cycloplegic refraction. Good to do are the open field AR, axial length, binocular vision, and the tear film assessment. And exploratory refraction or a research examination would be a peripheral refraction, pupillometry, aberrometry, or a macular OCT. Now, risk factors for increase in progression are the environmental risk factors in terms of decreased outdoor activities, which is very common these days, increased near work, again, which is very common, and digital screen time, which we all are fighting for most of the kids when they visit our hospital. Younger age of myopia, higher baseline myopia, past myopia progression, parental myopia, they all can predict progression, but none of them can give you the rate of progression what the child is having. That is very, very personalized. Now, when to initiate anti-myopia therapy? Whenever the myopia is progressing at the rate of more than 0.5 diopters per year for a younger child having a parental history. These are the indications when we should start thinking of initiation of the anti-myopia therapy, but do not try and initiate anti-myopia therapy in case of ROP or a congenital cataract because the mechanism here is different. The current modalities, whatever we have been evaluated for younger children between 4 to 6 years of age to up to 12 to 16 years of age. So do not try and initiate myopia therapy in a very young child or a very old child. Optical intervention in terms of spectacles are very good. We have always been doing, but now we have availability of DIMS, progressive addition lenses, and bifocal spectacles, specifically in cases of esophorias and accommodation lag. Some companies are giving these spectacles which are commercially available for dispensing. But the cost of spectacles is sometimes withholding for the child. We can also plan for orthokeratology or soft multifocal contact lenses, but we all know that multifocal contact lenses or orthokeratology, they have their own problems. And they may also need a spectacle backup when the child is not wearing these contact lenses. Low-dose atropine is one of the most easily acceptable and documented kind of anti-myopia treatment in the Indian scenario. It is a non-selective, irreversible anti-muscarinic agent. It is available in various concentrations from 0.01 to 0.1. Beware that the child doesn't take 1% because we don't want it. And 0.1% is commercially available and is passed by the Drug Control of India. And this can be used very commonly. I usually prefer to give them at a nightly dose so that they don't forget. Higher concentrations can be given if the patient is still progressing. But when we give higher concentrations, there are problems of near vision and glare, and photochromatic glasses and bifocals can be required in such cases. Low-dose atropine does have a rebound phenomenon, especially when the higher concentrations are used. We have to take care of the contraindications for use of atropine, and we should not be giving atropine in those children. Lifestyle modification is very important. Ask the children to go involve more in the outdoor activities, reduce the near work, decrease their screen time. Other measures like 20-20-20 rule, ambient lighting while reading, adequate posture, sitting on the chair table while reading, they are all helpful in reducing the myopia progression, and they are also helpful in pre-myopes so that we can reduce the development of myopia. Other points, like we should understand the children who have multiple risk factors, they need more strategic management and frequent review. One can maintain a myopia growth chart or a normal chart also, which can be kept. The duration of treatment is usually 2 to 5 years, and WHO limits it for 2 years. Again, for the orthokeratology or for multifocal contact lenses, again, the duration of treatment is 2 years. But yes, a longer treatment can be given if the child is progressing. We all know that some children do tend to progress despite our best efforts. So if they are progressing more than 0.5 diopters, it is called as progression. More than 1 diopter per year is a rapid progression. And the characteristics of non-responders usually are both parents being myopic, younger age, high baseline myopia, and previous history of faster progression. In such children, you can plan for higher concentrations of atropine, or maybe we can plan a combination therapy with atropine or DIMS or any other combination therapy we all know of. Now, when to stop? When the myopia stabilizes, a treatment period of 2 to 3 years. Whenever we taper the atropine and we find there is a progression of myopia, we may think of recommencement of the therapy, and switching from one therapy to another can also be considered when the myopia is progressing. So I think that's all we have in the present day for anti-myopia. Thank you.